I'm delighted to introduce Fiona Kent, who is Associate Dean Learning and Teaching and Director of Collaborative Care at Monash University, Australia. She's a physiotherapist by background. She's had 10 years interest in interprofessional education. Her background as a physiotherapist was in stroke rehab and teams, and that suddenly probably increased her awareness for effective and efficient collaborative interprofessional practice in the practice setting. And she's going to talk about recent developments in interprofessional collaborative practice in Australia. And at the end of her presentation, we would welcome questions, discussion, and things like that. You can put your questions in the chat room if you want, or keep them until we're ready. So thank you very much, Fiona.
Thanks, Richard. I'll try and keep my eyes on the chat if someone's got a burning question, or we're a little group, so I'm happy for you to butt in. Recognizing my context where I'm from, I'm at Monash University in Melbourne, so southeast of Australia, but I'm also representing some other organisations. So APIN is the Australian and New Zealand Interprofessional Network, which is a member of Interprofessional.Global, but also some of this research is funded by the Health Professions Accreditation Collaborative Forum, so a piece of work that's being funded by our Medical Council and our Pharmacy Council, looking at accreditation of practitioners across our healthcare setting. Kicking off, I need to acknowledge the traditional owners of the land that I'm on. I'm on the land of the Bunurong people, and pay my respects to elders past and present. And for those of you that don't know, Australia is having a referendum in the next couple of weeks to recognise Indigenous people's voice to Parliament. So it's quite an exciting time. And I guess this theme I'll come back to of making sure voices are heard is really important in terms of decision making, etc. I was going to end with this quote, and then I flipped it at the end to say, this is the patient's voice up front. So I'll just let you read this, which comes from our research. Essentially, when we were asking our public what collaborative practice was, the message was pretty clear that what their expectations were. For everybody, I'm definitely on my evening coffee. For those of you just waking up, morning coffee. Coffee is appropriate throughout this, so that's entirely fine. What I'm going to do is talk a little bit about the Australian context so you understand the regulation matrix, I guess. Progress that's been done in getting interprofessional collaborative practice across our health workforce to date. And then two important pieces of work that I've been involved in recently. One's called the Statement of Intent, and one's around the Health Professions Accreditation Research. So context. Obviously, everyone's aspiring for the collaborative practice, which is experienced by our patients, families, carers, communities. The main APRA is the Australian Health Practitioner Regulation Agency. So they set the rules, the standards, audit practitioners, set the priorities, etc. And one of the pieces of work that's I'm going to talk about today, the Statement of Intent, that's coming from APRA. So it's across all our healthcare workforce, I guess, which closely links to what the national boards do. So all the regulated professions, medicine, nursing, physio, occupational therapy, etc. We've got 15 boards. And then we've got some self-regulating professions, nutrition and dietetics, speech pathology, etc. So two sort of levels, I guess, of regulation at the profession level. And then there's a layer of what the accreditors do for courses. Now, obviously, APRA, the national boards, and accreditation are all quite closely linked. And the second piece of research I'm talking about today is around the accreditation authorities, which obviously links quite closely to what the education providers do, which is where I work in a university. So whoever sets the rules of what should exist in education and how that's delivered. And the obvious final big piece of the puzzle is practice setting, so how healthcare is delivered. And for context, it's also worth knowing really that the way our healthcare system is funded, Primary care is largely national funding, and our public hospitals are state funding, so Victoria, New South Wales, etc. So the way healthcare is delivered and funded and the way we work is also determined to some extent by where the funding sits and how that occurs. So the practice setting piece is another big determinant for collaborative practice because funding and models dictate that. But the ones I'm focusing on today are the piece of work from APRA and the accreditation authorities. Recognising a whole lot's come before me. So APIN, the Australian and New Zealand Interprofessional Group, that kicked off 2006 before I was involved. And then there's been some nationally funded big projects scoping out what IPE is being done at universities around Australia. An audit, there's a big piece of work with Jill Thistlethwaite around an interprofessional assessment tool. And then more recently, a piece of work around the architecture or how it should be, IPE should be organised at a national level and the governance, etc. All of these pieces of work have, I guess, made small steps towards what we want to achieve. And it's also worth noting in 2017, a group of academics established a set of competency standards with the intent for that to be used across all our professions. But the uptake was not great. And some reasons for that is that not all voices were around the table, I guess, to establish what those competency statements were. So the uptake across all our professions didn't occur. The waves here is the waves of funding, of energy, things that have happened in bursts over the years. Just a couple of years ago, our colleagues in Queensland, the north of Australia, did a piece of work that looked at all our professions to say, what are the statements in medicine, nursing, physio, etc. accreditation guidelines around what should be happening in interprofessional education. And what they found is, although most of our professions had some sort of statement about these students should be learning to work together or they should have IPE in their curriculum, it was really varied in what that actually meant. So what even IPE was, how IPE was understood, and the expectations of it were really varied. So although the vision is there, we've aspired for interprofessional curriculum or learning to exist in all our courses. It just means different things to different people. So that's a limitation really in terms of implementing it. And also, just for context, we know an interprofessional framework's super useful for building curriculum, but as many dots as there are on my little map of Australia are as many interprofessional frameworks that I guess are being used. So some of our universities, such as mine, have developed an interprofessional curriculum framework so that we can build curriculum. So my university's got 12 health professions and we have a framework and we embed activities across that. But similarly, some of the universities around Australia have used the Canadian guidelines or in the American guidelines, etc. So depends on where you work in Australia, what you think the competencies are, what you think the interprofessional framework would look like. So this again is problematic. But where we're at, so in the last couple of years, a few biggish national pieces of work. So the Interprofessional Collaborative Practice Statement of Intent, and I'll talk to that in a moment. There's a piece of work being done at a national level around terminology. Now I know Interprofessional.Global has done that work around trying to standardize what we mean by all this terminology. But a similar piece of work is happening in Australia so that our different medicine, nursing, pharmacy, etc. are all on the same page when we say what is IPE, what is collaborative practice, etc., so that it can be interpreted the same by all of us. And then there's this big piece of accreditation research, which I'll also speak to. So big point number one is Interprofessional Collaborative Practice Statement of Intent. So you can see by the dates, this is essentially a 2-3 page document which has a vision for Australia having a collaborative healthcare workforce. And essentially it says we're inspiring to have embedded in education, in training, in clinical governance, and in practice processes that facilitate collaborative practice, meaning it's not the role of one of these pieces only, it's the role of organizations and structures and systems across all these domains. And the format of this is really based on a successful statement of intent, which came from working with the Aboriginal and Torres Strait Islander strategy. So similarly, some years ago, all APRA, the boards, the organisations, etc., agreed to a vision of this is what we want in healthcare for Aboriginal and Torres Strait Islander people. This is what we value. This is what we're going to do about it. So although our collaborative practice is in draft form, this is essentially where we're trying to get to, which is really, we're stating where the end point. The piece of work that has to come after this is how do we go about doing that? So if we've said we all agree that we want a collaborative healthcare workforce that with shared visions and shared responsibilities, the second piece of work will be the action plan. And with the Aboriginal and Torres Strait Islander strategy, that is exactly what's happened. There is a work plan and there's curriculum, etc., that follows. So I think this is super exciting, and it'd be no surprise to people in this group how fiercely language is debated, the words we use, trying to get everybody on the same page. But we're getting there. So the first round of national consultations gone out, and we'll soon see hopefully something close to our final version. The next piece of work is this big piece of accreditation research. So we went out to ask patients, education providers, accreditors, etc., this question about, in the contemporary Australian healthcare setting, what is collaborative practice? What are the attributes of a collaborative practitioner, and how can the accreditation organisations facilitate the development of a collaborative practitioner? So it's a big piece of work, but to cut to the crunch, I guess, what is collaborative practice? This is where I was saying in the chat earlier, the message really clearly is the feeling that the patient is too low in the hierarchy. They want to be elevated to at least be a team member, value placed on the lived experience and as the expert in their own healthcare. And to some extent, the hierarchy of healthcare to be reduced. They didn't want what we see and the way we practice is deemed to be hierarchical and not useful. So with comments such as, we need to be teaching from the get-go, from university all the way through, that this industry has no place for egos. Treat everyone as an equal. You work together or you're of little use in this industry. Patients first and foremost. And this other comment from our consumers, I think if they didn't fight over turf and saw their services as complementary. So really this idea from our consumers, somewhat critical of the health workforce, of too much hierarchy, too much power, too much shenanigans. They wanted their voice to be more strongly heard and less of the hierarchy, which was really quite a strong theme in terms of collaborative practice. A whole lot of equalising needs to occur, increase patient voice and reduce hierarchy of health practitioners. The second big thing that came out of what is a collaborative practitioner is that this is entirely context dependent. So we need to be really clear if we're sending messages about what is collaborative practice. It's very different in palliative care, in rehab, in community settings, in an emergency site. So whatever our recommendations are for teaching, to be aware that context specificity is incredibly important, rather than simplifying teamwork as a simple construct that you would you'd pick up at university and just slot it in whichever setting, because the scopes of what people do, how people work together, how communication occurs is entirely context dependent. And the next question in that piece of research is, what are the attributes of a collaborative practitioner? And there's lots of ways of sorting out how we make sense of that. But we use Billett's domains, really looking at the knowledge, skills, and attributes, essentially, of a collaborative practitioner. And if I cut first to all the conceptual, so all the knowledge, here are the domains that our patients, educators, accreditors, health providers thought were the key knowledge domains. And I'll just let you read those, because some of them are very similar to what we've seen on previous interprofessional frameworks, and some of them are a little bit different. So particularly noting what that final item was, really how roles are changing in different systems, and COVID fully flipped what some people were doing within their specific roles. From there, to look at the procedural competencies, so the skills that you would see someone doing if they were a collaborative practitioner. And once again, I'll let you read those. So once again, really similar to what we've seen in some of the other frameworks, I guess the digital technology and how we're communicating through EMRs and messaging and whatnot, it's a different form of communication between amongst colleagues. But many of those other attributes are things we would have seen before. And just so strong through all the data was all the dispositional, so the attitudes, the values, so this idea of respect, trust, dignity, treating with humility, being reflective. This was so strong, particularly from the expectation of patients of what they're wanting from their health practitioners. No longer the super confident I guess expert without critique of their input to someone's healthcare, really looking for some of the humility and dignity and compassion, etc., throughout all these items. And the next aspect of this was really, well, what can accreditors do to try and develop a collaborative practitioner? And this was really interesting in that, similar to, once again, work that's been done elsewhere, but looking for, within university courses, etc., evidence of university faculty school commitment. So is there an interprofessional framework or vision or statement or whatever that is, to actually look at the programs that exist, which is pretty obvious, to look at what the student experience of interprofessional curriculum across a course would be, not within an activity. Really interesting to say, well, what are the health services doing as part of developing a collaborative practitioner for all the students that are on placements and practitioners that are already working? And we found this quite interesting. Rather than saying it all belongs back at the university, develop the collaborative practitioner to insert into the health system, this expectation that some of this work should be happening within the health service, where much of the clinical placement time is, and really valuing and giving merit to both formal and informal activities. And also looking at staff resources, like where is there actually dedicated people to the development of the collaborative practitioner, whether it's at university or in health services. We also did a piece of work at Monash University when we put our framework in place to go, well, how useful are frameworks anyway? If we're all saying the point of this is to develop a collaborative practitioner, does a framework make any difference? And to cut to the answer, yes, absolutely, but not exactly in the way we thought it would. It really assists educators by having a clear framework on what you should be delivering in terms of collaborative practice. It allows everyone to use the same language. It allows, it means the priorities are already agreed on. So the work in an education institution is just the implementation. The work is not trying to make a decision about what sort of curriculum needs to exist. So for us, our interprofessional framework has 4 themes: person-centered care, role understanding, interprofessional communication and collaboration in teams. So all our IPE activities have those 4 themes in it. That means if you were developing a new activity, you don't have to start from scratch. You've already got the framework in place and you just modify it for delirium, respiratory care, aged care, you know, whatever piece of, whatever level of learner that you've got. And this is a quote really from that piece of work: that rigorous debate amongst professions, especially over language. All professions have got their own language. And this is where a framework really helps. It means everyone's using the same language, so we're all working to achieve the same thing. And certainly, the second quote there, for those working in big universities or across universities, we need people trying to achieve the same thing. Once again, with different language, it doesn't help the development of the curriculum and therefore the practitioner. By having a framework, it allows a whole of curriculum approach rather than individual activities, because it's much more strategic. And quote here demonstrating that since the frameworks come along, medicine's really looked at their curriculum, found areas where they could add or tweak and identify where they were meeting the objectives and find the gaps. So once again, by using a framework on existing big courses, it allows you to know what to change and do differently. But also really important message for us in universities is that most of this meaningful learning is occurring in the workplace. So the data from this study is we tracked graduates 6 months out. So we were no longer looking at what they thought about their activity when they were at uni. We interviewed them, so our medical, nursing, physio, OT, etc., interns, grads, 6 months later, and looked at their rating of what they'd learned through university, what they learned at orientation, what they learned on placements, and what they learned as a new graduate. And the meaningful learning that occurs through team meetings, through shadowing, through chats with people in the corridor or whatnot. So I think there's a really important message for us that not all our effort should be going at what happens at the university. We need certainly equal effort and to prioritise what happens in the workplace. But also that what they told us is, although they're learning the basics of collaborative practice before they graduate, that learning curve is massive as a new graduate because it's context specific. So learning to be a nurse in the emergency versus a medical ward versus a clinic is so different. So once again, our expectations of what we want to achieve by graduation, the basics as opposed to the depth that occurs once someone graduates, which will always be context specific. And certainly in that, when we were interviewing both grads, but also their employers, that expectation to manage difficult conflict or the challenging things in the workplace, they weren't really expecting that of a new graduate. They would expect if there's conflict and something very challenging, that you would escalate that to senior staff. So we found that interesting as well. So if I come back to, you know, where we started, where we've landed, certainly in terms of the APRA, the statement of intent, we're getting to the point in Australia where we're all agreeing that we will work together to establish a collaborative practitioner through all these levers. We will get to the point where we will be able to tweak what accreditors are looking for so that at least we're all using the same language, looking for the same things in terms of accrediting courses. But I do come back to what's occurring in practice settings. So whereby how healthcare is delivered, which is limited by funding models and ways of working and location even of where different practitioners work. That's just another big piece of work that needs to be considered. And limits, I guess, the extent of how much we can collaborate, even if an individual has those skills. Put them in a setting whereby collaboration is not facilitated or limited really by the physical environment or the funding model. It's too much to expect the individual to have ideal practice in that system. So where I've landed to, we are getting to the point where we have a shared vision. We're getting to the point where we're getting a national consensus of what we're aiming for. Certainly a national framework would be a really useful curriculum tool so that we don't have so many of these separate interprofessional frameworks depending on which university or which state you were working in or which profession. So I think that's the next piece of work. And certainly across our APEN network, those in universities that don't have one yet are just saying, can I just use one that already exists rather than working to develop that up? We've learned very clearly about the value of learning across universities, placements in the workplace. So not all the focus should be at university. We should really be increasing our emphasis about the workplace. And also that context is super important and needs to be considered at all levels. So I come back to the patients that are telling us we need to catch up, we need to be listening to our patients more, we need to rethink hierarchy, etc. And there's a whole plenty of resources there, which I'm really happy to share. That's it. I'm going to stop talking. Richard said, try and keep it under the time limit. So I think I'm within there. But yeah, really interested in your thoughts and what resonates and what's different, given there's lots of different healthcare settings here.
Thank you very much, Fiona. That was an excellent presentation, and I'm sure it's resonated with a lot of us. There's obviously very similar comparisons of the UK with Australia, especially with our medical colleagues. No disrespect to them, but and I think very much patient-centered. I don't know if Alison wants to add something. I'm going to pick on her because last week she hosted a Cape Regional Forum, and that was very much how they engaged with patients. Any comment, Alison?
Yeah, we actually had, it's so funny talking about the terminology because I'm a midwife by trade. So we just don't use the word patient because that has the connotations of someone who's sick.
Yep.
So I would say service users. So it's just quite interesting. We're still talking about the different language, aren't we?
Absolutely.
But it was great. Yeah, it was great to have a service user actually presenting at an interprofessional forum, and so their voice was very strongly heard. So it was great. But I love everything that you've done, and I'm on the Cape Standards Working Group where we're looking to develop standards. So I'm thinking, oh, I'm going to be looking your name up. But thank you. Great presentation.